Hello, my name is Dr. Yvette Efebera. I'm advisor for gender-based violence and child marriage in the Gender Equality Division at the Bill and Melinda Gates Foundation. And I'm honored to be able to speak with you all today about sexual and gender-based violence, a global perspective. Over the course of the time we have together today, I hope to accomplish three aims. The first is that I want to provide you with some background and an understanding of what it is we're talking about when we say sexual and gender-based violence, or gender-based violence as you'll hear me refer to. Number two, I want to share with you some example from women themselves, from research I've done in the past in Conakry, Guinea, in West Africa, to help bring to life this experience that we're talking about. And then number three, I want to talk about what do we do with all of this information and this understanding, and what are its applications in global health and in the healthcare profession more broadly. If there is one thing that I hope you'll walk away from this talk with, it's this, that gender-based violence, sexual and gender-based violence, impacts the health and well-being of individuals all over the world, and you, as future healthcare professionals, have a key role to play in both prevention and response. So with that, let's go ahead and dive in. And let's start first by providing you with some background on gender-based violence. So first of all, what are we even talking about when we say gender-based violence? What is it? Well, we draw from the United Nations definition, which calls out physical, sexual, mental harm or suffering that occurs in public or private spheres, to a broader definition that we use actually at the Gates Foundation in the Gender Equality Lexicon, which says this: gender-based violence is violence directed at an individual based on their biological sex, their gender identity, their gender expression, or their failure to adhere. It includes physical, sexual, psychological abuse. It can occur in public and private life. But what's important here to recognize is that it doesn't have to only be focused on women. It's actually all individuals who have the potential to be impacted. Now, in the definition of gender-based violence that I use, I actually include sexual violence within that, particularly recognizing the explicit reinforcement of gender norms and inequalities within its definition. But some people do like to be specific about sexual and gender-based violence in order to call attention to this additional construct. Now, if you look below, you can see a word cloud that I put together to show you different terms, different ways in which you meet different forms of gender-based violence that we do know exist. You might have heard, for example, of intimate partner violence, which focuses on violence that's directed from one partner to another across domains of physical, sexual, economic, psychological, just to name a few. Sexual coercion and rape are forms of sexual violence that you may have heard of, which get captured within this broader umbrella of gender-based violence. Violence against women is something that you'll probably hear often referred to, which is actually a more narrow form of gender-based violence that really focuses on the experience for women and those who identify as women. There's other forms of violence, though, that are also worth calling out. Femicide, which is female homicide. Again, this is a form of gender-based violence. And there are traditional practices such as female genital mutilation, forced marriage, and in some contexts, child and early marriage, which are also viewed as forms of gender-based violence. Regardless of what you call it, it's important to recognize that there are many experiences that get captured in these terminologies, that not all are the same, although they interact with one another, and that there really is an important opportunity for us to better understand and to intervene. I also want to call one more thing out about terminology here, and that's this. Over time, actually, we've seen evolution in which terms are used where and when, and we do see different contexts that use different language today. For example, if you're in South Africa, you might hear gender-based violence used to refer particularly to experiences of violence targeting women and girls perpetrated by a heterosexual partner. If you're in the United Kingdom, you might hear the government there refer to violence against women or violence against women and girls, designed to explicitly call out women as the targets, the victors, the survivors of these practices, and to engage with where feminist communities are coming back to today. Regardless of what you call it, again, we are talking about really similar constructs that point towards violence that is happening and that is targeted at an individual based on their sex, gender identity, or gender expression. So why does it matter? Well, let's talk about first and foremost the magnitude of the impact that this has on populations all over the world. I'm going to focus particularly on statistics for women and girls because those are the populations for which we know the most, and the numbers are alarming. We know that 1 in 3 women, more than 730 million women, have experienced physical and/or sexual intimate partner violence, or sexual violence from someone other than an intimate partner over the course of their lifetimes. And these experiences start quite early in life. In fact, according to the World Health Organization, nearly 1 in 4 15 to 19-year-old girls reported experiencing violence as perpetrated by a current or former partner. These rates are also astronomically high when we think about murders of women that are caused by a male intimate partner. And when you look among younger women, girls under the age of 18, 1 in 5 report being sexually abused in her lifetime. We know that gender-based violence is important because it has harmful consequences for individuals, for their communities, for their societies, but also because it violates the rights of each individual and it prevents progress as a globe, particularly with regards to sustainable development. Of note, one of the Sustainable Development Goals, the 17 global goals that almost every country in the world agreed to advance in order to pursue development over a 15-year period. Of all of those goals, one is focused on gender equality, and within that, there are specific indicators that explicitly call for the elimination of all forms of violence against women and girls in public and private spheres. This reminds us that there is already a global commitment towards ending violence against women and gender-based violence more broadly, reminding us that we have a lot of work to do. I want to also make the point here again that I'm going to focus mostly on girls and women based on availability of data and the magnitude of the issues that we know exist for this population, remembering that gender-based violence affects all individuals of multiple gender identities. So where does gender-based violence exist? Well, the short answer is that it exists everywhere. Let's look at the example of intimate partner violence, though, to better understand this. So if you see the image that's on the screen here, taken from the World Health Organization's report released last year, focused on new estimates for violence against women between 2000 and 2018, they did these really robust analyses to better understand estimates of intimate partner violence worldwide. You can see on the map that there are these yellow circles that point to the lifetime prevalence of violence perpetrated by a current or a former intimate partner, physically and sexually. And you can see that across regions the rates are high. For example, in North America, you actually see nearly 1 in 4 women reported experiencing intimate partner violence for women who were in those 15 to 49-year age groups. Rates were similarly high in Latin America, where you see the yellow circle is the same size and has that same prevalence of intimate partner violence. What might be particularly shocking to realize, though, is that other regions where we often hear about these experiences happening also have similarly high rates. In sub-Saharan Africa, the number is 1 in 3. In South Asia, we see a similar number, 1 in 3. In many European regions, 1 in 4 women are reporting experiencing intimate partner violence in their lifetime. And then you can see in the Asian regions, actually, that we see higher rates present there. In fact, in some countries, it's even reported that 1 in 2, 50% of women in the 15 to 49 age group are reporting intimate partner violence. Now, a couple of important things to note about this data. First of all, these estimates were produced prior to the COVID-19 pandemic. And we do know from a new study from UN Women that actually there has been increased reporting, particularly of violence against women during the COVID-19 pandemic. Secondly, it's really important to call out that not only pandemics, but also other emergency conflict and humanitarian settings can exacerbate the risk factors leading to increased reporting of gender-based violence. So there's a particular concern and a particular understanding that's necessary in those contexts. And then lastly, I want to call out that there are certain types of violence that may be more prevalent in some regions, but also that may be just reported on more and or monitored differently in different contexts. So for example, when you look at this figure, just because rates are higher in one region doesn't fully explain what might be happening leading to that increased reporting. And additionally, there are types of violence, such as, for example, female genital mutilation and cutting, where there are clearly regions where the rates are the highest for these practices. So we've talked about what gender-based violence is, why it's important, where it exists, and we've specifically honed in on the examples of intimate partner violence, right? Violence perpetrated from a partner in the context of a relationship, as well as sexual violence, which might be perpetrated by someone other than a partner. But let's talk a little bit about why this might persist. Now, I'm pulling here this image taken from a paper by Professor Lindsay Starks and colleagues that provides a really helpful ecological framework for understanding that the risk factors for gender-based violence occur at multiple levels in an ecosystem. This framework was built and expanded upon the original work in this space by Professor Lori Heisey back in the late 1990s. So what does Professor Stark and colleagues say here? And I'm going to focus on the left-hand side of this figure. Well, first of all, starting from the bottom of the figure, we have to understand that there are individual risk factors that support the persistence of gender-based violence. And these could include things such as experiencing violence as a child or witnessing abuse as a child, use of substance or alcohol use, and attitudes around acceptance of violence. At the next level of this ecosystem, the relational level, there are another set of risk factors that might be contributing to the persistence of gender-based violence. This includes, as Stark and colleagues say, stigma, shame, and silence, or marital conflict, which I'll talk a little bit more about when I share some examples from my own research. At the community level, expanding in this ecosystem, we see another set of risk factors that might play a role. To just name a couple of them, that could include explicit support in the community for violence against women or support against it, as well as health services not being as responsive. And then lastly, at the societal level, at this most macro setting of the ecosystem, we see still more factors that could be contributing to gender-based violence, including discriminatory laws and practices, or a lack of prioritization of this issue, particularly as it affects women and girls. What I think is really helpful that Stark and colleagues call out, and as I briefly mentioned on the previous slide, sometimes there are additional contexts, such as in humanitarian conflict settings, where there are an additional set of risk factors that may heighten what potentially may be exacerbating this crisis. And as for those of you who have been following the news, that's probably very much at the forefront today as we think about the situation, in Ukraine. So the last piece of background context that I want to share before I go into a specific example is to talk a little bit more about what we know about how gender-based violence relates to health. Now, according to the World Health Organization, who has a really helpful fact sheet on their website, there are a few buckets of ways of which we understand how GBV is related to and has impact on health. First of all, a lot of evidence shows that it has both short and long-term consequences for physical, mental, sexual, and reproductive health, particularly for women. That includes, in its most severe form, mortality, death, as a result of gender-based violence. But it also includes physical injury, reproductive health outcomes such as unintended pregnancies or increased sexually transmitted infections, mental health issues across a range of domains, and in some cases, a connection to increased reporting of risky behaviors, such as increased reporting of smoking or substance use, particularly as associated with sexual violence. We also know that gender-based violence has an impact on the health and well-being of children, particularly those who are born to women who are survivors of violence. To give a few examples there's increased reporting and associations of things like miscarriage and stillbirths, preterm delivery and low birth weights associated with women who report higher risk or experience with forms of gender-based violence. There's increased reporting of behavioral and emotional development in issues in children who are born to women who are survivors. And in some cases, we see increased infant and child mortality and morbidity associated with forms of gender-based violence, particularly along the lines of intimate partner violence and sexual violence. Lastly, both the World Health Organization and UN Women actually call out that there are some really critical social and economic costs to women, families, and societies as a result of violence. Of note, UN Women did a study back in 2016 and found that violence against women actually costs $1.5 trillion US. That's 2% of the global GDP. This is the cost of an action, the cost that is associated with not adequately responding to and ensuring that especially girls and women are protected and are safe. This is a constant reminder for us who work in this community that we have so much more to do. All right, so we've talked a lot about the context behind gender-based violence or sexual and gender-based violence, as you may choose to refer to it as. But I want to hone in now on a specific example and use that as an opportunity to help bring to life what we're talking about when we say experiences with gender-based violence. So I'm going to take you to the West African country of Guinea, a country of 13 million individuals, a French-speaking, predominantly Muslim country, where 1 in 2 women marry before the age of 18. That is what we refer to here when we say girl-child marriage. And what I think is really important to point out about the context of Guinea, and especially in the nature of child marriage, is that it is actually illegal according to national legislation. Women are not supposed to marry before the age of 18 per Guinea's law. Now, I was particularly interested a few years ago when I did this research, prior to my time at the Gates Foundation and during my time as a researcher in the gender and global health space. I was particularly interested in better understanding why this practice was so persistent despite the existence of national law. And I really wanted to better understand women's experiences themselves and how they themselves perceive their experience in their child marriages to affect their health consequences. The guiding research for the guiding research question that I had was how, if at all, do women who are married as children in Conakry, Guinea, see their marriage as related to their health? And I want to acknowledge here that this work is published in the Journal of Social Science and Medicine and was co-authored by my dear mentor, the late Dr. Paul Farmer. So how do we go about thinking about this research? Well, first of all, I used a grounded theory methodology, which is to say that I didn't just go up to women and ask, how does child marriage impact your health? Instead, I took no preconceived notions about what that relationship might be, designed a set of research tools and methodologies that allowed women themselves to share their experiences in marriage, to talk about their health. I probed further to start to understand where there might be connections between the timing of their marriage and the consequences. And I both asked women through a set of interviews, as well as observed and participated at their invitation in elements of their lives. The sample for the study included 19 women whose first marriage occurred before the age of 18, and I sampled until I was hearing a repetition of key themes coming up. I won't say much more about the research methodology here, but I do want to call out that ethics approval was received both from my institution at the time, as well as Guinea's National Ethical Research Board. And as you see pictured here, myself with a local leader, I sought to also get permission from local stakeholders before entering into their communities to do this research. All of the methods for this study are published in that article I mentioned in the Journal of Social Science and Medicine. So what did we find? Well, let me start by first talking about who was included in this sample. So of the 19 women, there was actually a range of ages, the youngest being 17 years of age, the oldest being 60. So there were multiple generations represented in the study. The women in the study represented multiple ethnic groups, multiple ages at marriage, though all before that 18 cutoff, as that was a criteria for inclusion. Most were still married at the time of interview, and they had a range of education levels as well. Now, I'm not going to talk through the full study today. Again, I'd encourage you to see our study as published. But what I do want to call out is that participants described a total of 9 different thematic areas, which fell into 2 large buckets, one about perceived health disadvantages that they experienced, and one about perceived health advantages that they themselves experienced in the nature of their early marriages. I'm going to focus on one of the themes of the perceived health disadvantages, which is a theme called abuse I endured. Now, in this particular theme, women described physical, sexual, psychological, and economic abuse that they experienced in the context of these early before 18 marriages. These experiences were perpetrated by in-laws, neighbors, and extended family. So those are things that we might call domestic violence or family violence at large. But the most severe forms that were described by the women who brought up this theme in the nature of their interviews in the study were inflicted by the spouse. That is what we know, and as we started this conversation with today, with regards to intimate partner violence. Now, the women described that the abuse they experienced led to poor physical and mental health and had lasting consequences across several areas, such as experiencing physical back pains or headaches, visual impairment, and physical scars, to name a few. Nearly all of the women who described violence grew up in poorer households, and all of them would be considered to have married at very early ages, so before the age of 17. Most of the women in my sample who also talked about experiences with abuse I endured also were no longer married, telling us something about the severity of the experience for them. I also want to just call out that in our sample, we didn't see any connection between the participant's age or their education level, which is important to help us understand that violence occurs across a domain of areas, regardless of some components of your background. So what are a few examples that came up in this theme, particularly with regards to the intimate partner violence that women experienced? Let me share with you 3 examples. Fatimata, whose name I've changed to protect her anonymity, a 27-year-old who married at the age of 16, shared her experience with physical intimate partner violence. In her words, she says, "One day he threw me. When I carry something or I do certain exercises, my back directly stops there. Also, when I feel the head pain that I have, I would say it is the blows that I received to the head. Before, I did not have cyanitis. One day he poured hot water on this foot, and the scar remains today." And in fact, she showed me the scars all over her body, her arms and her legs, that were the constant reminder of the physical abuse that she endured in her early marriage. Another example from Bintu, a 45-year-old woman who married, in her words, at her own choice at the age of 16, described experiences of sexual violence within the nature of her intimate partnership. In her words, she says, "The bad experiences that I had, he plugged the heater to me, he hit me, he held me down. He undressed me one night, he told me undress as when a man needs a wife. He watched me, things that I never explained to my mom." And she went on to explain the ways in which sexual violence became a recurring theme for the time that she remained married. A last example that I'll share here comes from Hajia, one of the youngest in this sample, a 21-year-old, who also married at the age of 16. And in her case, she describes violence, intimate partner violence that airs more on the economic and psychological side. In her words, she says, "We fight each time, arguments. He chased me out of the house. Even when I was 9 months pregnant, I only waited for the day of delivery. He chased me from my home at 1 o'clock in the morning. I went to my aunt's. It was the next day that I gave birth to my little girl. I gave birth. My husband didn't come. No one. The negative things, but I can't speak a lot because sometimes this makes me uneasy." She went on to talk about the challenge of economic resources in her home, the way in which her husband withheld resources from her, the ways in which she constantly experienced mental anguish and trauma as a result of the economic and mental, psychological, intimate partner violence she experienced in the context of her early marriage. So again, I've not talked through the whole study. There are some other insights there that I think are particularly interesting and insightful. But what I really want to call out is this last bullet point here, which is to say that we have to listen to and incorporate the voices of women themselves when we think about designing successful policies, programs, research, etc. And in the ways in which you, who are future healthcare professionals, will interact with and support the many that you will serve. If there is one thing that I really took from that research in Conakry, it really was the nuance with which understanding these experiences and concepts in the words of women themselves from their stories helped to bring to light the startling statistics that so many of us continue to hear on a daily basis today. Now, with this particular study, of course, I have to take a moment to really acknowledge the 19 women who shared their stories and invited me into their homes. I have to acknowledge my research team and my support system in Guinea, including my 2 research assistants. And I have to acknowledge my research advisors, including Dr. Paul Farmer. Rest in power. I'm grateful for the funding that I received as well for this research. Now, the very last thing that I want to talk about here, and I'm just going to take a few minutes to do this, is to pivot us to the last topic, which is what do we do with all of this information and what are its applications to global health? So let me just share with you 3 slides only in order to help get you thinking about opportunities to be an advocate for gender-based violence prevention, response, monitoring, and accountability. First of all, I want to call out that we know more than ever before about what works for gender-based violence prevention, and yet gaps still remain. Now, a couple of years ago, I led a landscape for us at the Gates Foundation to get a better sense for where there were key gaps and opportunities, where there might be opportunities for us as an organization to lean in and focus more. And one of the most compelling frameworks, one of the most compelling tools that came up in that landscape, that came up from dozens of interviews and resource reviews that I did, was something called the Respect Framework. This is a framework that was put together by 13 different UN organizations that has input of experts all over the world and that really help us to understand the key strategies that can help to prevent violence against women as a particular form and a really key form of gender-based violence more broadly. Those 7 key strategies fall along the lines of each of the letters of the word respect. R, relationship skills strengthened, an opportunity to strengthen the ways in which individuals and couples relate to one another, the skills that they have. E, empowerment of women. And this includes economic empowerment as well as social empowerment as a way to address and help to prevent violence. S, services ensured. Now, this is an area that's really critical for healthcare professionals because health services are one of the many types of services where there's an opportunity to ensure that individuals, survivors, are reached. P, poverty reduction. Another risk factor, as we know, for violence is poverty and economic imbalance. So there's an opportunity to intervene there. E, environments made safe. Again, there's a key role for healthcare professionals here, given that many of you will work in environments like in a healthcare facility, where an ability to protect and safeguard for those who are survivors is really critical. C, child and adolescent abuse prevented. Again, a key area, particularly in screening for healthcare professionals, recognizing that there are intergenerational linkages between experiences of violence. And lastly, T, transformed attitudes, beliefs, and norms. This is an area that's of increasing interest today, really thinking about how you can shift and transform norms that may be counter to preventing violence. Now, I'm not going to go into a lot of detail about the types of interventions that fall into each of those strategies that I just talked about, but I will encourage you to check out the Respect Framework as well as the Inspire Framework, which is the violence against children version of the Respect Framework, that provide really helpful tools and understandings, including those that can be used by healthcare professionals and providers to better understand where and how there are opportunities to intervene. At the root of all of this, and I don't want us to forget this, is really the safeguarding of those who have been impacted, the challenging of unequal gender dynamics, and the need to think about programming that touches on multiple sectors, disciplines, areas, of which health is a key one. So let me go a little bit further into the important role that the health sector has to play. And I've taken these examples directly from the World Health Organization's Violence Against Women website, fact sheet, that you might also find as a useful resource. So the WHO tells us that there are 5 ways that the health sector in particular can play a key role. And I hope that you as future healthcare professionals will be thinking about if and how you can do this in your own work. One is to advocate to ensure that we understand violence, gender-based violence, is unacceptable and that we have to understand that as a public health problem. Number two, the health sector can ensure that there are comprehensive services and appropriate training that is trauma-informed, culturally intentional, and sensitive, that is holistic for healthcare providers in order to respond to the needs of survivors. Number three, there's an opportunity in the health sector to ensure early identification of women and children and other survivors who are experiencing violence and ensure that they have appropriate referral and support. That is a really key area for the health sector and for healthcare professionals in particular, to avoid the perpetuation of a system in a space that doesn't adequately support survivors. Number four, the health sector can promote egalitarian gender norms. And we can do that not only in the ways that we individually model things, but also in the training, such as through life skills or comprehensive sexuality education curriculum that's being taught to young people. So any of you who are a part of curriculum development, remember that there's an opportunity to expand our understanding of gender norms, which can help to target some of the underlying risk factors or root causes of gender-based violence. And lastly, number five, the health sector can generate evidence on what works and understand the magnitude of the problem in order to continue to have attention on the importance of a multi-sectoral, including a health focus, in response. Now, I want to point to the fact that there are some really exciting examples globally of efforts to try to scale up a focus on understanding gender-based violence in healthcare systems. And I'll just give you one example from work we've supported at the Gates Foundation. ARCHES, which is a project that is run by the University of California at San Diego's Center for Gender and Health Equity, in partnership with the International Planned Parenthood Federation and the government of Kenya, are actually looking at how to leverage healthcare facilities, how to ensure that healthcare providers are adequately trained in order to recognize, to capture, to monitor, to intervene at that healthcare level for women's experiences in particular with violence. So I would encourage you to check out interventions like ARCHES if you're interested in learning more. Very last thing that I want to say here is just that there are some really exciting advocacy opportunities that have been emerging that are looking to reprioritize a focus on gender-based violence in health and beyond. Let me put two of those on the radar in case they're not already there for you. The first on the right-hand side pictured here is the Generation Equality Forum, a major global moment that happened in 2021, but that has set up action plans that we hope will be executed and accomplished over the next 5 years. As one of the 6 key priority areas within the Generation Equality Forum, a place that was committed to by governments, but also by private sector leaders and young feminists, people from across disciplines and fields. One of those critical areas that was called out was gender-based violence. There's an action coalition that has put together a blueprint of some of the key priorities of areas that can be advanced over a 5-year period in the space of gender-based violence. So there's renewed attention, a movement, and a commitment towards advancing this over the next few years. The last thing I want to call out for you, and this is something that I've actually done more in my pre-Gates life, I'm part of an association called the Society for Adolescent Health and Medicine, which is the association that sponsors the Journal of Adolescent Health. And over the last couple of years, a group of us, including healthcare professionals, some of whom are physicians and providers, some of whom run healthcare facilities, some of whom, like myself, come out of a research and practice background. But we came together and have been working to call additional attention, particularly for the adolescent and young adult age group, to the harms of gender-based violence. One such example is a commentary that we published last year focused on femicide, one very severe form of gender-based violence that often doesn't get a lot of attention. This coming year, we're hoping to write a position paper that will actually help to provide some really concrete tools and and skills and resources that healthcare professionals and organizations can use when focused on the adolescent and young adult age group when focusing on gender-based violence. So I hope you'll stay tuned and continue to keep an eye on other associations that create advocacy spaces for healthcare professionals to share, exchange, and come up with solutions. With that, I want to say thank you for your attention today. And let me just briefly remind you what we've covered over the course of the last 40 minutes or so, and what I hope you'll take away. As a reminder, we've talked about background on gender-based violence, inclusive of sexual violence within that, and the startling statistics that exist. We've talked about some examples of women's experiences in the context of Guinea, Conakry, and West Africa, where I've done some research prior. And we've talked a little bit about what we can do, some tools that exist, and some applications for an understanding of this concept into the health sector at large. Again, what I hope you will take away, if only one thing, is a recognition that this is such an important area for health professionals to focus on, that gender-based violence is, in and of itself, a crisis on many fronts, including a public health crisis itself, and that you all as future healthcare professionals have such a critical role to play. Thank you so much for the opportunity to speak here with you again, and I look forward to hearing and learning about the ways in which you will drive action on this forward in your own work now and beyond. Thank you.